Namaskar. You are watching Dr. KK MEDtalks Fridays with Dr. Anita Kant, non-stop show, 1030th episode. Let's have the headlines of the day. Recent statistics reveal that nearly 50% of pregnancies in India are high risk. The incidence of PS is approximately 1 in 50 if there has been one cesarean section and 1 in 6 after two previous cesarean sections as a result of the increased use of cesarean as a mode of delivery. Ultrasound MRI may help in diagnosis of placenta accreta spectrum disorder, states a study. Antenatal diagnosis of PS could allow for early multidisciplinary care, reducing PS-associated maternal morbidity by up to 80%. A recent study published in the journal Scientific Reports reported that circulating microparticles, that is CMP proteins, predict pregnancies complicated by PS, and that is a very good technique. Now let's go to the topic of the day. जैसा कि अभी मैंने आपसे बताया कि आज हम बात करेंगे प्लेसेंटा एक्रीटा स्पेक्ट्रम के बारे में। आज हमारी स्पेशल गेस्ट हैं डॉक्टर नम्रता हाडिगल। अनफॉर्चुनेटली अभी वो एक इमरजेंसी में बिजी हैं। शी इज जॉइंड अस, सो नाइस ऑफ यू। गुड इवनिंग डॉक्टर नम्रता. So, Dr. Namrata Hadigal is a distinguished medical professional with an extensive background in obstetrics and gynecology. With an MBBS, DGO, and DNB qualifications, she specializes in laparoscopy and hysteroscopic surgery and fertility treatments. Dr. Hadigal has served as the medical director of Narmada Fertility Center and Endoscopy Center in Secunderabad for 15 years and holds consulting roles at GVK EMRI Hospital, Geeta Hospital, and Rainbow Hospitals in Hyderabad. She brings 37 years of expertise in the field, including teaching roles at Osmania and Gandhi hospitals, and significant international experience as a consultant for the Ministry of Health in Iran and research in high-risk pregnancy at Emory University, Atlanta. Dr. Hadigal is also an advisory board member for Advanced Life Support in Obstetrics, which is called ALSO, and an executive member of ITACS India, reflecting her commitment to advancing medical practice and education. So, Dr. Saab, let's start the show, if you're comfortable. Okay.
Yeah, I'm comfortable. Thank you for the inviting me, and also sorry for the delay. Yeah.
No problem. I hope your patient is doing well. So,
Yes.
what is this placenta accreta spectrum, and how does it differ from a normal placental attachment?
Yes. Placenta accreta, this is a very big spectrum. These are the disorders, and actually, we are going to discuss about the challenges and management risks when we treat with the placenta previa. Usually, this placental accreta, and in this form, I will do just an introduction and a classification of the risk factors and pathophysiology, how to diagnose it and management, and recent advances in the field of this placenta accreta. So the placenta accreta means this is usually attaching into the myometrium. Usually placental will attach in the decidua basalis, whereas this placental accreta, after decidua basalis, it will go deeper into the myometrium. That is a little part of the myometrium. So that will become as adherent placenta. And so this is the morbidly, it is called morbidly adherent placenta. So morbidly means it is showing that it is very difficult to tackle, and because of the penetration of the placenta into the uterine wall. So this is one thing, and it is a most dangerous condition as well. And the actually this word is derived from the Latin, AC plus creta, they call it like this. So with this, and patient may land up in PPH. That means large amount of bleeding can occur, and also they may undergo hysterectomy, and they may have to admit in intensive care units, and they may have to admit after delivery also, and they're prone for more infection, prolonged hospitalization, and sometimes in 7% of placental accreta cases, even mortality of the maternal mortality will be also there in 7% of cases. The hemorrhage may be fatal, and it can be lead to DIC, disseminated intravascular coagulation. That is a coagulation disorders also can occur. So why we should know about this placenta accreta disorder? The average blood loss in all the women after delivery is 500 to 1 liter of blood. But whereas in this placenta accreta disorders, it is 3 to 5 liters. That means almost all blood in our body at the immediately after delivery, we lose so much of blood. So, what are the other risk factors when we tackle for these, and when we do surgeries for these type of things, and even we may harm bladder as well as ureters, because we have to do some surgeries, and all these things, not only for mother, and also for the baby. Prematurity may occur for the baby. The premature things also can occur. So that is the reason it is very challenging thing. So so many challenges we come across while managing this type of cases, because what is the pathology for this? And the neovascularization. We just thought that it will normal placenta is in the deciduous basalis, but whereas when it is penetrating into the myometrium and neovascularization, that means new blood vessels will form and in the myometrium, and also the piece of this placental unit, placental unit is very much. I mean, circulation is very high, and why this circulation is very high also we will talk later. And for this we have to initially only we have to plan and organize, and procedure skills also we should know, and we should detailed and multidisciplinary attention we should have, and one thing we have to give blood for blood. That's it. Blood transfusion has to be given, and we have to see coagulation system and other I mean parameters of blood also to be seen. Coming to the what is the instance of this placenta accreta means,
Yes,
it is
yes, yes.
globally previously in 80s and in 70s, and when we in 80s when we were students, hardly we used to see cases like it is one case in 2004 or 1000 cases we used to see. But because of the increased cesarean section rate now in general population now, and we are seeing more number of cases like one in 500, if you see cases, at least one will be the placenta accretal disorder kind of thing. So this much it has increased. So this why I mentioned it as a spectrum means, because placenta accreta is one thing, placenta percreta, next placenta increta. Placenta
Mhm.
accreta means only it is almost 70% of cases it is common. It will enter only this placental tissue enter only into the myometrium. But whereas the placenta increta, it is almost 15%, and the incidence is 15%, but it will enter up to the I mean serosa of the uterine cavity. Then this percreta, it will penetrate the serosa of the uterine cavity, and not only serosa, and it will enter even into the bladder as well as the surroundings. So the instance is 5 to 7%. So what are the risks that we encounter during doing this, and why we should why people get this? And of course there are few risk factors are there, and when we always see placenta previa. Whenever we see placenta previa, we should always think about the placenta accreta. And usually, and this placenta accreta is most of the times associated with the previous cesarean section as well as the placenta previa. So, and not only that, in sometimes in vitro fertilization cases, when we put embryos, when we insert embryos, sometimes sometimes trauma to the decidua basalis can occur, and also when we put embryo, because of the little bit more media if we put, that may come down, the embryo may come down, implant in the lower uterine segment. And these three factors, that is placenta previa, placenta with cesarean section, and also IVF cases, and these cases have proved, and they have consistent control studies what they did. But whereas in other things, like if patient is having prior history of the placenta accreta, and prior history of any surgeries in the uterine cavity, like uterine synechiae or Asherman syndrome, prior endometrial ablations, like we do surgeries for AUB and other things, and also uterine fibroid prior uterine fibroid emboliations, and congenital anomalies of the uterus, like rudimentary horn, and also prior uterine irradiation for any other disease like that. And also not only that, and it is seen most of the times above the 35 years of age, and prior dilatation of the DNC, prior dilatation of the uterine cavity, and MTPs, and resection of the myoma through, hysteroscopic guidance, and also maternal smoking. These are the risk factors for the placenta previa.
Okay. So,
So coming to the,
are
madam.
there any specific symptoms or signs that a patient will know that she has some problem with the placenta?
Yes, yeah, we will come to that, and
Okay.
usually the problem is we'll discuss pathophysiology later, and also classification also will discuss later. The thing here is, usually patient when patient will go for this ultrasonography in the first trimester of pregnancy up to 3 months also. Sometimes ultrasonologist has to find out lacunae, because there is no clear demarcation between the uterine wall and the placental wall. So, and whenever it is adherent, like adherent placenta is there, the gap between the uterine wall and the placenta is very less. And also there we see and blood pools of lacunae. These things we can notice. And also not only that, and sometimes patient may complain that she is having bleeding. And most of the times, this placenta accreta will cause antepartum problems, like patient will have bleeding sometimes, and also intrapartum problems when we deliver the patient, and also not only that, in postpartum also infections, so many other things also they will have. This coming to this signs and symptoms in fifth month, if they go for anomaly scan, there also we can make out. Most of the times it is only ultrasonography. Patient may not tell that I am having, may not notice that she is suffering with the placenta previa, placenta accreta, and all these things. Only the thing is there, we have to, this is a this should be diagnosed by the ultrasonography and past history. And usually we do regular checkups for the patient, and we will send at least 2 scans in the antenatal period, at third month and also in fifth month, like that. And in fifth month also they see many things, like ultrasonography is the most commonly used diagnostic things for the placenta accreta disorders. And also sometimes when posterior placenta previa is there, we may have to subject them for the MRI. So in all cases we need not do MRI for to diagnose the placenta previa only, and accreta. In few cases we have to do, or otherwise in the rest of cases with ultrasonography we can make out.
Okay. And are there any implications, for the timing? Do we have to do a delivery a bit early? And
Yes.
is it a planned delivery and all that? Please tell about
Yeah,
that.
very good question, madam. And in third month, when the gestational sac is implanting on the cesarean scar, okay, that is when
Mm-hmm.
we divide the uterus into three quadrants. Upper
Mm-hmm.
quadrant, no. Second quadrant, no, no sac. Third quadrant, when it is implanting on the scar pregnancy, and in lower segment, that time we should doubt, oh, she may get either placenta previa or placenta accreta. So that time also we can, some people they inject, anyway the baby will not go up when the scar it is invading the scar, and uh, patient came for the first visit for the ultrasonography. So what we have to do, and if patient is, we have to explain to the patient about the problem, future problem, and if it is possible, that time only, and the people are injecting pot chlor inside the uterine cavity. I mean, fetal heart, and like a third month pregnancy, second month pregnancy, and methotrexate into the yolk sac, like that, and or else, and we should ask for some patient to come again and redo the scan. And Doppler studies are very, very important in these cases, because in Doppler studies we can come to know, like multiple vascular lacunae we can see, and ultrasonography is played major role in the placenta accreta disorders. And in fifth month pregnancies, if still it is there, and all again we have to subject her, that patient, for the Doppler studies, and we have to plan the delivery. And as you said, better the, I mean, we have to plan in multidisciplinary fashion. So where we have to deliver, that we have to think about it, and also when to deliver is more important. And usually I prefer between 34 to 36 weeks of delivery, and we should not let them go higher than that, because the placenta will become more mature, go much more inside the uterine cavity, and it is very difficult to take it out. And also for this, and my advice, and also we are thinking in Hyderabad that we should have, and mm, like we at one place, that is one in one hospital, we should subject them to undergo all these, all patients they should go there, because where we have good, I mean, good facilities, like we should have more blood, and blood products, and also anesthesiologist and intensive care specialist, neonatologist, and also vascular surgeons, general surgeons, urologists, and all these people have to be there to tackle such kind of cases. So and usually in USA, they have one art of excellence center is there nowadays. They are keeping, and center of one center where they do only placenta accreta cases, like and they practice, and they have good outcome, optimal results they should have. And also they teach to various centers also, like that. One group is formed in USA, that is placenta, where they deliver only placenta accreta type of cases, and with multiple uh, I mean facilities. So like that in India also, we should have in various hospitals with
Facilities,
all
yes.
these facilities. Yeah, center
Right,
of
right.
excellence should be there.
Center of,
So
yes. Definitely, that makes a lot of
yeah,
difference because they are
difference.
tuned to taking
Mm,
care of
yeah.
such patients.
Yeah,
Right.
whenever this ultrasonography, I mean, radiologist or gynecologist, whenever they see such kind
Mm-hmm.
of patients, and from the
Mm-hmm.
beginning, they should tell that patient should stay nearby hospital. They should not go back their home, because we don't know
Mm-hmm.
when the problem is going to occur. It is a like a atom bomb, like when it is going to burst, like that,
Explode. Yes.
ticking bomb kind of thing. And we
Mm-hmm.
should be very careful about these placental accurate disorders. And the treatment is also, of course we can multiple, and only one kind, single gynecologist, however they are experienced, they cannot, it is difficult. So they should have help and other things. And whenever in our how to manage this, like if we go for this management also, and we should have, we have conservative management as well as surgical management. In conservative management, most of the times in like what they used to do is they used to take out the placenta in the fetus after delivery of the baby, and that is expeditive approach. What they used to do, they used to take out, they deliver the baby and take out the chunks of placenta, but they where they used to have lot of bleeding. So they used to put pressure, give syntostan and prostadine and other medication like even vasopressin injections. They used to dilate and give into the uterine wall and other things. And also expectant managements in a few places. They used to deliver the baby and close the uterus, and placenta used to be there. And after what they used to think, it will absorb by itself. But in 60% of cases, patient got landed up in hysterectomies because they used to get lot of, puerperal sepsis, infections, and addition formation, and temperature, other things. Even after that, morbidity, maternal morbidity was very much high. So now we are doing one single step procedure. Single step procedure means that where we have to deliver the baby and take out the placental bed itself. We have to cut the placental bed. And then suture the bed with interrupted sutures. That is one step procedure. And triple P procedure. There, what they have to do means, and inside the operation theater, they have to see the placental edge from where the placenta, where is the edge of the placenta, upper border of the placenta. They used to see, and after seeing that, they used to plan. And after delivering, they used to see, and above that they have to cut, and above the edge of the
Okay.
placenta, they should not cut through the placenta or below the placenta like that. So above that, you should avoid the placental tissue in during surgery. So after that, and take out the baby and devascularize the pelvis. And if you can do, you can ligate the uterine vessels, or else you can ligate the internal iliac arteries, or else you can compress the aorta or common iliac artery with bulldogs. And now we have people are giving training in Madras and other places where we have to clamp those major blood vessels to the, to prevent this devascularization and that thing. Devascularization should be done. So then we have to, after that, after devascularization, we have to take out the placental bed itself and resuture the placental bed. Interrupted sutures we have to put like that.
Yes. That is a recent thing to avoid losing the uterus for the patient and also to
Yes,
saving her life. Yes. So,
saving her life. Yes.
yes, yes.
Yeah.
So,
As
what
maternal
advice?
mortal, madam, yeah, tell me.
And no, please ask. Please tell. Please.
Yeah. No, as maternal morbidity, we should have to prevent maternal morbidity. Of course,
Yes.
mortality that is there,
Yes.
and one more thing, we have to counsel a lot. This in these cases, counseling is very much important. We have to tell everything to the patient, and the patient may lose blood, and she may need blood, and baby problem, prematurity will be there, and injuries to the pelvic viscera like placenta, and all these things. Bladder. Sometimes even we may have to cystoscopy whether the placenta invaded, if percutta is there, if it invades into the bladder, we have to see the by cystoscopy. Sometimes resection of the little part of the bladder is also required, and ureteric
Yes.
implantation we may have to do. And of course some intestinal injuries and all those things we should do, like when we are doing all these things. And the uterine fistulas can occur. All these things can occur, no? We have to counsel them a lot. And also even we have to discuss about the mortality and morbidity of the patient, infection, readmissions, and ICU admissions. And this is a team approach, as I said. And we have to keep prepare even anesthetists to keep and pelvic, central lines also. We are supposed to put to know the how much blood we are pumping to the patient, how many IV fluids we are pumping to the patient, that also we should know. And will be, and because everybody will be under panic when patient is having PPH, and these things should be done. And also neonatologist, urologist, and whoever is available in the hospital, uh, yeah, they should be done. So that is the reason I always request our government to start some center of excellence for these kind of things. So with this we can protect we can prevent maternal mortality in India, because PPH is one of the atonic PPH, and one of the major causes for the maternal mortality in India. So we should decrease maternal mortality from 97 to 46 by 2030, by doing a few things like this.
Yes, definitely. So, in the end, what advice would you give to an expectant mother and her family who are facing such a diagnosis of PS?
Madam, pardon?
If there is a lady who
Yeah.
has placenta accreta or something like that, what advice will you give to that patient and the family?
Yeah, and so because recurrence is more, whoever got the placenta accreta, they may have another chance. And
Yes,
so when everything goes smoothly, I advise them to undergo tubectomy or vasectomy. They should not, because if patient had placenta accreta, because normally in 4% of all pregnancies, placenta accreta can happen. But whereas in first cesarean section, the chances of placenta accreta is 11%. In second cesarean section, it is 44%. In third cesarean section, it is 60%. Like that. In fourth cesarean section, it is 70%. Like that. It goes on increasing. So that is the reason, and we always better to advise them to. Go for a family planning procedures. But last, and my advice for the suppose one, without knowing, some doctor has opened the abdomen for the cesarean section. They found the placenta previa is there and placenta percutta, because we can see the uterine surface, like blood vessels will be there, and also engorgement, bluish discoloration of the vessels will be seen on the top of the uterus and the
surface.
cirrhosis uterus, surface of the uterus. So immediately better to close the abdomen and send it to a referral center. So better
Yes,
don't do in the periphery, because instead of doing and getting into all these problems, and we need so much of blood and other facilities, so many doctors, so many specialties, and referral center we can, like teaching hospital, and where the blood and other facilities are available, and close the uterus and send them back, like
right.
that.
That is a very good advice. Thank you, Dr. Narmada Hadigal, for joining us
Yeah,
today. Could you show us the certificate, please?
yeah, please. Did you send it, madam?
No, no, she's just showing it to you. Could you?
Thank you, thank you.
This is a
Thank
small token of thanks from our side to
thank
you
you.
for being with us. And thank you so much. You took out your precious time to be with us. Thank you. And that will be all for today. Dr. KK MEDtalks will return tomorrow at 7 p.m. with another edition of the show. Keep watching Dr. KK MEDtalks. Namaskar.